Good morning. Today I'll be taking a topic sources of anchorage in orthodontics. As we all know, once we start fixed orthodontic treatment, a major consideration is to bring about changes in the anterior segment, that is the area which the patient is targeting, for which he has come to us for orthodontic treatment. And for taking the anterior teeth inside, or maybe for correction of crowding, we need to have anchorage from the posterior segment. Okay, that posterior segment or the anterior teeth, how they move, that depends on the tissue reaction, that depends on the periodontal ligament of an individual. That is the why the rate of orthodontic tooth movement varies among individual. So we have to have a thorough knowledge of this tissue reaction and limitation of the soft tissue tolerance. And besides this, as an orthodontist, we should know the mechanical principles which are involved during fixed orthodontic treatment, and this will give us a complete comprehension about anchorage planning in orthodontics. So major objective of anchorage planning is to maximize the desirable tooth movement and to minimize the undesirable effects. Now anchorage has been classified by different individuals. Like in Engel and Case, they defined anchorage as a resistance offered to the units by unwanted tooth movement. So during orthodontics, we want that whatever movement we desire, that should happen. But inevitably, some amount of reactionary tooth movement or undesirable tooth movement occurs. So how to stop that undesirable tooth movement is the motive of anchorage planning. Now Graeber, he defined anchorage as a nature and degree of resistance to displacement offered by anatomic units when used for purpose of tooth movement. Prophet, he also classified anchorage as resistance to any unwanted tooth movement. Nanda described anchorage on the basis of space closure after extraction of premolars, that is it whether maximum retraction of anterior teeth is needed or some amount of movement of posterior teeth is also allowed, or complete movement of posterior teeth is allowed. So depending on this, different authors gave different classification of anchorage. Now coming on to sources of anchorage. Now sources of anchorage could be intraoral or extraoral. Among intraoral, let's recapitulate. Among intraoral, we have alveolar bone, the teeth that depends on the root form, size and number of roots, root length, position of tooth in the dental arch, inclination of tooth and the mutual support. Third is the basal bone, that is maxillary and mandibular basal bone and musculature. Now coming on to teeth. Whenever anterior teeth are being retracted, posterior teeth, they act as anchor unit. The anchorage potential of the teeth depends on the root surface value. As we can see in this figure, that it is shown the root surface value in millimeter square is shown. Like you can see for central incisor it is 204,179 per lateral and so on. So and we see for the molar being multi-rooted bigger teeth, they have more root surface value compared to the anterior teeth. So when we are, suppose if we are individually retracting a canine, so canine has an root surface value of 273 while molar has 533. So still it has a more anchorage potential than the canine. So that is, even this is a simple form of anchorage where the canines can be pitted against the first molar during individual canine retraction. Like, but or if we are combining some and multiple units like second premolar, first molar, second molar, and obviously that root surface value will increase, and anterior teeth being lesser in root surface value, it will provide a good anchorage from the posterior segment. Now coming on to root form and root shape. Round roots of bicuspids and palatal root of maxillary first molar, they can resist horizontally directed forces but they offer least anchorage. Flat roots of mandibular incisors and molars can resist the forces better. Triangular roots of incisor and canines do offer resistance to displacement. Tripod arrangement of maxillary first molar helps in increasing its anchorage value. Size and number of roots. Root length. Greater the length of the root, greater is its depth of insertion. Hence, greater its resistance to displacement. Similarly, when there are more number of roots, like say maxillary first molar, which has 3 roots, which are flared also, there is an increased anchorage value. As you can see, flared roots, they have more anchorage value compared to first fused root. That is the reason why maxillary first molar, though in maxillary cortical bone, which is not so strong, but still because of its flared root, it is providing a good anchorage potential compared to other teeth. Position of roots. Now mandibular molar, they offer more resistance than maxillary molar because it's placed between two dense cortical plates. And mandibular second premolar also offers resistance as placed between mylohyoid and external oblique ridge. Now because this concept was used by Robert Murray Ricketts during his fixed orthodontic treatment using bioprogressive therapy, where he called it as cortical anchorage. So what he used to do, he used to torque the roots of the mandibular first molar buccally. So when the roots touch the buccal cortical plate, which is itself very thicker, it gets resistance to tooth movement. So then that is how he employed cortical anchorage during retraction of anterior teeth during use of fixed orthodontic therapy by progressive means. Now, inclination of tooth. Greater the resistance to tooth displacement is offered when the tooth is attempted to be moved in a direction opposite to its axial inclination. Okay, now suppose the tooth is being distally displaced, and then it has to become upright, then it will shift mesially, then it will be able to move forward. But suppose there is a premature loss of the tooth head mesial to the molar. So in that case, what happens? Molar is already mesial tipped, and when we are putting orthodontic forces, it would has a tendency to move further mesially. So there will be a anchorage loss. So mesial inclination of tooth is not desirable, especially when we have to preserve the mesial movement of the posterior segment. Now in chylous teeth, the teeth where the cementum and bone is fused, they have definitely increased anchorage potential. They provide increased resistance to tooth displacement. This is the reason at times even ankylosed teeth are used for reverse pull headgear to provide anchorage in the maxillary arch. Now better anchorage value is seen in teeth with good intercuspation, broad contact point and teeth moved mesially. Coming on to alveolar bone, it resists tooth movement but up to a limit. Dense alveolar bone seen in adults increases the resistance to tooth movement, and when we see in young adults, they have increased vascularity and there is increased cellular turnover also. That is why if you see, anchorage loss will be more in younger individual compared to an adults. If an adult patient comes to us and he has a missing 6, and if I want to move the 7 into that place, suppose one problem will be that both the cortical plates might be fused. There is less amount of cancellous bone in between. That will also hinder the tooth movement. Besides this, if everything is normal, then also the same amount of tooth movement and in young will be relatively easier because of increased cellular turnover, because of increased vascularity. Whereas in adults, there will be more resistance to such type of tooth movement. Means there the 7 will have a more anchorage potential compared to that seen in a young individual. Now basal bone, it is the area of basal bone like palate which reinforces the anchorage. So like suppose if I am using a Nance palatal button along with whatever means I am using, another intraoral means I am using for anchorage potential, say I am tying 6, 7 or maybe 5 to the making it a unit. So besides this, I am using a Nance palatal button where both the molars are tied by a rigid stainless steel wire and you have an acrylic button on the palatal vault. So what will happen here, I am taking anchorage from the palatal vault, which is a maxillary basal bone, and this will provide increase anchorage potential. Similarly, in mandibular arch, we can make lingual arch or we can add acrylic to that, like in lip bumper, and we can take help of the anchorage. Now, cortical anchorage, as I told you, cortical bone in mandible is thicker with less blood supply and bone turnover. Hence, if molars are taught to touch the cortical bone, it offers resistance to its movement. This was the concept of bioprogressive therapy given by Robert Murray Ricketts. Now, devices that make use of basal bone, they are known as holding arches. It could be maxillary holding arch or Nance holding arch. It could be mandibular holding arch. So as you can see in this first figure, as I told you earlier, it has two molars. They are connected by a rigid stainless steel wire. You have acrylic button on the palatal vault which will provide an anchorage. You can see there is a wire, there is a lingual acrylic button over it that is providing an anchorage. Then these are the maxillary and mandible removable anchorage appliances given by Setlane, which are not used routinely nowadays. So now coming on to when I know the sources of anchorage. In my previous lecture, we had covered the types of anchorage, and now I've told you what are the sources of anchorage. Now besides whatever these sources I told you, these all were intraoral sources. Extraoral sources we had already covered. Among extraoral sources, what we have, just to recapitulate, among extraoral sources we have the use of headgear, which is taking support either from the parietal region, occipital region, back of the neck, or if I am using it for class 3 malocclusion, it can take support from the forehead and the chin. So these are the extraoral sites which are providing anchorage depending on the type of headgear that is being used. Like you can say cervical pull headgear, It will use back or nape of the neck for providing a support. When I talk about hypal headgear, it will have a strap in the occipital and the parietal region. Combined headgear, they will have a strap on the parietal region as well as on the nape of the neck. So they will have the both advantages of both type of headgears, and disadvantages of each of the headgear will be negated by the other one. So these are the extraoral sites of anchorage. I have told you all what are the sources of anchorage intraorally. Now coming on to the last and most important topic is anchorage planning. So whenever I am starting any fixed orthodontic treatment, before planning what will be my mechanics, how I will take the teeth inside, how I'll relieve the crowding, the most important consideration will be my anchorage. How I'll hold my molars. So when determining space requirement to treat malocclusion, always consider the space lost by the movement of anchor teeth. How much I have to hold molar, what type of method I should use. If I am on the maximum anchorage, it will be suffice to use the intraoral anchorage, or we should take help of either the extraoral means like headgears, or we should take the help of temporary anchorage devices. So anchorage requirement depends on number of the teeth to be moved. Say this is the reason why two-stage space closure is done at times where canines are individually retracted. You can make a unit of posterior segment. You can reinforce with maxillary holding arches. You can retract the canine separately, and once the canines are done, canine being a longer tooth, you can incorporate it in the posterior unit along with 5, 6 and 7. This will make your posterior segment much more with more root surface value, much more anchorage potential, and then you can retract the incisors. Okay, so this will decrease anchorage loss in comparison to en masse retraction of incisors and canine. Type of the teeth to be moved. Teeth with flat and long roots like canine, they cause more load on the anchor teeth. That is, whenever we are doing an en masse retraction, in maximum anchorage cases, there is more chances of anchorage loss. Type of tooth movement. Bodily tooth movement is more taxing than the tipping tooth movement. Periodontal condition. Teeth with compromised bone support are less taxing. Duration of treatment. Prolonged treatment time places more stress on the anchor teeth. That is why you should try to finish the fixed orthodontic treatment within stipulated time so that you don't place undue stress on the anchor units. Okay. So this is all about anchorage planning. This is all about sources of anchorage. Okay. Thank you.